blessings. Thank you very much, Anna Marie. Ladies and gentlemen, thank you very much for having me here. In particular, can I thank two individuals. First is Professor Salim Al-Hassani. I met him in July in Manchester, and he invited me to this conference, and then he put me in touch with Professor Al-Bashir, and he very quickly made the formal invitation. Thank you very much. Basically, my brief is three. One, a simple introduction. Two, I need to make mention about the organization that I'm with, i.e. the Federation of Islamic Medical Association, FIMA. And three, zoom into the area of interest of FIMA, Islamic bioethics. Yeah. Our good plastic surgeon made mention about men who remember history will make history. Actually, he adulterated the sayings of a Spanish philosopher, George Santayana, who said, those who do not remember history are condemned to repeat it. So what you guys are doing is brilliant, because you are celebrating people in history who have contributed to the welfare of mankind. And there is an authentic tradition from the Prophet Muhammad sallallahu alaihi wasallam, which says, "Khairun nas anfa'uhum linnas." The best from amongst you is those who serves humanity the best. So we are celebrating some of the best who have preceded us, and we hope we can emulate some of their characteristics, their inquisitiveness, their passion for new knowledge, science, new skills, and writings. Yeah. FIMA, the Federation of Islamic Medical Association, in one of its domain of interest is looking at the ethics of medicine. In fact, when I did my small research, probably the first person who engaged vis-a-vis the ethics of the physician was Ishaq bin Ar-Rahawi. I pronounce it right, yeah? Yeah, he from 854 until 931, and he wrote a text called Adab al-Tabib, Adab al-Tabib, yeah, which is the conduct of the physician. Brilliant, yeah. And in fact, because of his works, the Caliph Al-Muqtadir in 931 made it compulsory for every physician in the land to be licensed before he can practice medicine. Yeah, that is accreditation, credentialing, because the Caliph found out that one of his citizens died because of the negligence of a physician. And probably the closest to Ar-Rahawi that I can think about, and it's very close to you guys in Fez, is Maimonides. You can see his bust out there. He was trained, he came 300 years later, he was trained in Cordoba, and I believe he still has a house in Fez. Wallahu alam. So, this is my second brief. FIMA. We are about 37 years old, right? And I have actually known virtually all of the founders. They are my mentors, my teachers. This guy here, Al-Marhum, Sheikh, a cardiothoracic surgeon, Ahmad Al-Qadi. He started it with this guy right here, Professor Said Mubin. He's a psychiatrist from Pakistan, and to his left is Hussein from South Africa, a urologist. They came together in Florida in 1981 and started FIMA. That was the vision of our predecessors. Amazing, yeah? And the aim being to foster unity between the healthcare professionals, yeah? To bring our science together, our hearts together, promote healthcare services, education, and research, and to mainstream the ethics of Islam in medicine, yeah, and mobilize our manpower for the welfare of humanitarian relief. I'll show you some examples very quickly, and then very importantly, like what we are doing now, doing now is to collaborate with you guys in this aspect of rahmatan lil alamin, mercy for mankind, mercy and healing, shifa, healing for all mankind. So our members from 50 countries, from Australia in the east to the United States of America in the west. Morocco was a member. In fact, I was in Marrakesh in 2009 when we held our conference there with the Islamic Medical Association of North America. By the way, Dr. Sharif is the president of BIMA, Britain Islamic Medical Association. This is the exco for the next 2 years. You see, it's a mixed bag. This guy on the left sitting down is a public health expert from Jordan, and this guy is a cardiologist from Malaysia. This guy is a radiologist from Pakistan. Parvez is a plastic surgeon. Ataullah is an endocrinologist, a public health guy, and well, I've never grown up. I'm a pediatrician. Right, so there you are. This is the international networking that we have from the United Nations since 2005, the World Health Organization, the Organization of Islamic Countries, and all of these humanitarian bodies. And we hope, inshallah, we've made the next link with you guys here in Fez. Your work with the heritage is wonderful. Yeah, it's awesome. This is the relief work that we've done, humanitarian relief, bringing healing, shifa to humanity from Bosnia in 1992, Chechnya 99, Kosovo 99, Afghanistan 2001 when it was bombed, the earthquake in 2003. I was in Kashmir in 2006 during the earthquake. This is an overland journey we made from London across Europe to Turkey, and then we're in Latakia in Syria, where we were stuck for 3 weeks because we were negotiating with Mubarak to go across to Palestine, to go across to Gaza. Right? There were about 300 volunteers, 150 big trucks with 6 million USD worth of educational material and food stuff. Yeah. And we, the Malaysians, we drove, you can see there were six trucks there. And that's Indonesia 2009, and this extends to humanity. And we were in Haiti in 2010, we were in Puerto Rico recently. That's Pakistan, Libya, Somalia, Gaza. You know, Gaza in 2014 when it was bombed again by the Israeli occupying forces. Yeah, in 2014, we in FIMA were the first team to come in with the humanitarian relief. Yeah, at Syria, Malaysia, we had floods then, and now as I'm speaking, our boys are in Palu, Sulawesi, to deal with the victims of the earthquake and tsunami. This is some of our projects. FIMA Safe Vision, probably the largest as far as I is concerned. 20 countries, we were in 20 countries, in about 600 ICAMs. We've seen 2 million patients, and we've done 200,000 cataract surgeries. You made mention about cataract surgery by Az-Zahrawi. We've done, this is Az-Zahrawi in the field, in the camps, yeah? And for this, we were awarded by the American College of Physicians. A bit strange because we're a Muslim body, awarded by an American college, and the award is actually a Jewish award, Linda Rosenthal Award. And this is FIMA Say Smile. You know, you are a plastic surgeon, reconstructive surgeon, very delicate work, but we can do it out in the open. Look at this guy here, such a handsome boy after the surgery. We've been in 6 countries, done about 2,000 of this. Yeah, this is even more problematic. You talk about the obstructive labor, yeah, and how it created vaginal fistula and vesico-vaginal fistula. They were passing urine from the vagina, stools, feces from vagina, and because of obstructed labor, poor OBGYN practices. And we've done, involved 88 surgeons, done about 30 camps, about 2,000 patients now, yeah, and the success rate out in the open is 85%. Yeah, so there you are. So we make an investment in students. I just had a chat yesterday with the students from Al-Bashir students. Yeah, about 50 of them came. Investing in the young. Yeah, our inheritors. Yeah. So you see, you've had camps in Abaha in Saudi in 2001, right? In Tripoli 2004, Egypt 2005. This was the first camp that we held in Malaysia in 2005, and we had girls and boys together, right? And this is in Indonesia, and then we were in Langkawi again in Malaysia. My daughter was a student then, and she handled the camp with her 16 friends, right? I was just there to oversee and just give some content. They did it by themselves. Students trained, yeah, with the skills, yeah. By the way, she's now in a pediatrician herself. This is in Egypt, and then we also have this Umrah camp. We train our students in Makkah and Madinah Al-Munawwarah. And again, we have a consortium of Islamic hospitals and medical colleges. And this brings me to the ethics beat. You may say it's an obsession to make sure we do things right. Right? We do things right. As is expected of the Quran, traditions of the Prophet, and the jurisprudence of the fuqaha, of the religious scholars. And we have this journal, the International Journal of Human and Health Sciences. You can get this online. We've already published 4 within a space of 4 journals within a space of 6 months, and it's indexed by Google Scholar, Crossref, and Index Copernicus. The next step is PubMed, inshallah. And this is the yearbook that Al-Bashir wanted me to specifically talk about. Yearbook FIMA, right? We've had it since 1996. The topic that he wanted me to talk about was yearbook 2016. This is very quickly looking at the yearbooks over 16 years, yeah, all the topics. And this is 2016, right? It's actually part 3 of our Encyclopedia of Islamic Medical Ethics, and this one was focused on medical care at the end of life. An extremely sensitive subject, very difficult, all right? It's a time bomb, but we need to deal with it, yeah? And the starting point is, again, the priorities of the Islamic jurisprudence, maqasid syariah, in the context of Islam. These are principles that we have to adhere to very, very carefully. Yeah. In a situation of difficulty, it is always important for us to prioritize ourselves, i.e., we need to preserve morality and religion. And look, this is where we come into place as surgeons, as physicians. We need to preserve life. And this is base, and this is what inspires us. It is a verse from the Quran in Surah Al-Ma'idah, وَمَنْ أَحْيَاهَا فَكَإِنَّمَا أَحْيَا النَّاسَ جَمِيعًا. It's inspirational. You save one life, it is as though you save the whole of humanity. This keeps us going despite all the difficulties, all the odds. And to preserve progeny, intellect, this has all got to do with our medicine. But indirectly, it also involves property, because medicine is expensive, but our budget is finite, but the problems are infinite. So it involves being very prudent with our spendings. Yeah. And of course, We are also guided by the Prophet's prayer where we talk about end of life issues, whereby he said, "Oh Allah, please let me live if that is for my good, and please let me die if that is better for me." I.e., the one who decides is not us, but it's God, Allah subhanahu wa ta'ala. So, when we talk about end of life issues, these are really painful, difficult dilemmas, not just for us as physicians, but for the patients, for the family. Yeah? How much should we allow our loved ones, our patients to suffer? Should we do everything that's under the sun to keep them alive, even though the long-term prognosis is poor? Should we allow the ventilator, other life support modalities, cardiac drugs, right? Inotropic support, yeah? Or should they be discontinued upon our advice or upon the request of the patients and their families? And should we consent to DNR, do not resuscitate? These are advanced directives either from the patient prior to him or her getting into coma, or from the family members. And an equally important priority is how much longer can we afford? I mean, it becomes a financial catastrophe for some families. Yeah. So we actually dealt with these very difficult issues in our yearbook 2002. Right? You can see this. We talked about aging, we talked about the living will, we talked about brain death, end of life issues, the right to die, euthanasia. But because of new technology, new science, we can prolong life. But that equate with quality of life, QOL, the art of living. All right? So very quickly, if I may summarize what's in the yearbook, we looked very quickly at the 3 P's of aging: physiology, psychology, and the politics of aging. All right? If you look at the global life expectancy in 2015, it was 71.4 years, ranging from 60 years in Africa to 77 years in Europe. And yes, at the same time, talking about the politics of aging, we need to realize that this geriatric population still have contributions to our human society in terms of their skill sets, in terms of their experience, in terms of their wisdom. There is still an investment in the society. And it is with this that we can frame what's called a holistic program for end-of-life care and the peculiar challenges that comes with it. So there are certain ground rules that is extremely important that we have to adhere to. Very important when we talk about Islamic ethics within the context of the issues of end of life. Allah says that there is a tradition from the Prophet ﷺ that says there is no disease that Allah has created except that He also has created a remedy. So that is an instruction to the Muslims to research, to find for remedies, to treat, yeah, and to eliminate diseases. So the scholars say that if a medical intervention is found to be effective, found to be safe, and it correlates with good recovery, cure, then they opine that it is mandatory to undertake the treatment, wajib. However, other forms of treatment, the default rule is optional, i.e. not mandatory. In fact, some scholars would say otherwise. It is sunnah, while even fewer scholars would say that it is wajib. So these are ground rules we need to know. So if the chances of a cure or recovery from an illness, a critical illness, a cancer, a myocardial infarct, a stroke, is virtually nil, there is therefore no religious rationale for ruling that it is wajib, i.e. you must do everything under the sun to save this guy, even though he's got a cerebral hemorrhage there and he is in a vegetative state. So extremely important for us to recognize this. Therefore, not beginning to use a respirator or choosing to discontinue the ventilator or not choosing to intubate or choosing to extubate is simply choosing not to operationalize the optional rulings. Very important. Sorry, it's a bit busy, but it's extremely important. The physician cannot be penalized if he chooses not to intubate to a man that is brain dead, right? Nor should he feel any guilt when he does not choose to operationalize an action that is optional, that is ikhtiyar. However, we need to always remember that preservation of life is a priority of maqasid sharia, the priorities of the sharia. So we should always endeavor our very best to preserve life. However, when a cure or recovery is not a realistic expectation, or the treatment options are an exercise in what we call medical futility, no benefit whatsoever, no maslahah, or the treatment entails extreme measure, right? Then we may opt to withdraw or withhold such treatment modalities, and we should counsel the patient and the family accordingly. Patient is on the ventilator, brain death. I mean, the physician needs to tell the family. It's difficult, but you have to tell. This brain is dead. So you need to consider extubating, remove the patient off the ventilator and see what happens. And of course, it will be death eventually. But at the same time, despite doing this, so what I'm saying is that no heroic measures, yeah? But at the same time, we make sure that the patients continue to enjoy appropriate medical and nursing care, the best medical and nursing care, not compromise. TLC, tender loving care, maintain their fluid and nutritional requirements. That's why in the case in the United States of what's the name? Chauvet, where vegetative state, right? The husband wanted to stop the IV line, wanted to stop the feeding, while the parents said no. Went to the court, ding dong, ding dong. Finally, the husband won. They removed the feeding tube, they removed the IV line, and Terry Chavo died. Died from basically dehydration and malnutrition. That is not right from the perspective of Islam. You still need to maintain your fluids, nutritional requirement, and provide optimal pain relief. Use of opioids, yeah? Encourage hospice care of the terminally ill. So in that case, I could not understand why that lady was in the hospital and using valuable resources. It would have been more humane for Terry Chavo to be in her house, in her room, with her family, fed by the father or the mother with the feeding tube, and to die peacefully in her home ambience. Yeah, that would have been more humane. Yeah. So our palliative care for the terminal ill must be holistic, caring for not just the physical but the psychological, social, spiritual well-being for the patient as well as the family members. It's also very important for us when we deal with the youngest, the oldest, the geriatrics, and the critically ill. We check with the patient or the immediate relatives whether there were any advanced medical directives. Example, no DNR. If I have a myocardial infarct, no resuscitation, no intubation, no ventilation. You have to ask this, and you have to document this. That stipulate the patient's choice of medical care or intervention should he lose his mind, become demented, or enter a stage of coma when he cannot then make any decisions. So it's also important from the Islamic perspective, apart from the physical healing, we must manifest our empathy by comforting our patient, encouraging them to beseech healing, shifa, patience, sabar, perseverance, istiqamah, and rahmah from Allah subhanahu wa ta'ala. Euthanasia, which is licensed first, I think, in Netherlands and now in a few countries in the world, is categorically prohibited, haram in Islam. Okay? And we also encourage our patients to practice of talqeen, to remind themselves, because our living is a continuum from here to the hereafter. So always reminding them in their critical end-of-life moments of the remembrance of Allah subhanahu wa ta'ala. So those were the 16 chapters that I tried to summarize here. This, by the way, is our 2017 yearbook, Encyclopedia of Islamic Medical Ethics, Scientific Biomedical Research, the Islamic perspective of research. Yeah, we've done this. I wrote the editorial for this. I'm leaving copies for Al-Bashir and for some of your medical faculties in I think you got 6 medical schools. I think I have enough for each of your medical school in Morocco. All right, and next 2018, yeah, we hope we come out on the bioethics of reproduction, from contraception to sterilization to IVF, surrogacy, semen, over, embryo banks and donation, posthumous impregnation, adoption, beginning of life, right down to fetal sex selection, which Dr. Sharif has volunteered, and PIGD, pre-implantation genetic diagnosis. So if you're very keen to contribute to our yearbook, these are some information that will be very useful. That's my email address. You can text me, or you can Google. All of our books are online. All right, it's free information. FIMAweb.net. Thank you very much for your kind patience.
We actually have time for questions, and the 3 final speakers are very inspired, and certainly hopefully we'll ask students who have been enjoying to be amongst us this week. If the speakers would like to come up, and we can take some questions. Questions? Anybody?
My question actually is for Hamza, for Musa, it's very important. The debate of the ethics is taking place in the West, but perhaps less in the East. What do you think? I mean, you've summarized a good number of the cases in there, and you've asked for guidance. Do you have a way of leading the jurisprudent experts to understand the dilemmas and the intricacies of what the physicians and the doctors or the medical professionals are facing, so you can perhaps simplify it or show them the details and say, well, we need a legal way from religious point of view, rather than leaving the medical profession alone in this dilemma.
Thank you very much, Dr. Gumati. Muslims have never had issues with bioethics because there was never a separation between the spiritual and the mundane life. And that's why when Ar-Ruhawi first introduced the Tabib, Adab al-Tabib, it was natural. You know, they were already practicing it. And similarly with the Judaism theology, right? That's why my Mohd, who is a rabbi, a scholar as well, right? he came up with his principles of ethics in medicine somewhere around 1100s. Yeah. The problem with Enlightenment or Renaissance was that there was this separation between, or secularization between what is spiritual and what is personal and what is state affairs. And that is that break, that divorce. And that's why the modern world only knew about ethics or addressed the issue of ethics after the 1940s, after what the Nazi Germans did to patients in the war camps, yeah? After what the Americans did to the Negroes, did to the prisoners, you know, they jabbed them with syphilis bacteria to find out the effects of syphilitic meningitis. This had to be addressed. And then Buchem and colleagues came up with the 4 tenets of autonomy, maleficence, beneficence, and justice. Something that was already being practiced by the Muslims physicians, not just ethicists, Muslim physicians. Wallahu alam.
That it's very lucid, this deliberation by Dr. Musa. The problem which arises from here and what delivered here, there is a gap in between the development of history of medical ethics in medical science. As you described that these principles of ethics, beneficence, non-maleficence, justice, and all that, it is started from the Hippocratic Oath itself. There is. But what happened after these Nazis experiment or that age, we directly jumped to the Helsinki Declaration. In between the Helsinki Declaration and between this Greek and Arabs physician, there is no history at all on record. This is the main vacuum which should be fulfilled in the history of development of medical ethics.
Yeah, he's very right, because one of the principles that was anointed by Hippocrates is primum de nocere.
All 4 principles are there in the Hippocratic
That is
Oath.
on and maleficence. Primum non nocere. So just a little bit Latin. First, do no harm. Right? And if you go to history, there was not actually a void. That's what I emphasize to you, that Isha al-Rahawi rejuvenated this concept of the ethics of the physician. Adab al-Tabib. Yeah? And then which was further taken into more detail by Maimonides. But as far as the new civilization was concerned, Renaissance, there was definitely a huge void. Yeah? Wallahu alam.
This will have to be our final question.
Thanks very much. I just want to make a quick comment. Yeah, back to the bioethics, not only for the physician-patient relationship. I think we are having a bit of dilemma nowadays. I'll just bring a little example what's happening in the West. For example, in England, in Britain. Now, the organ donation issue, for example. Now we are going into the opt-out technique. I don't know if you're aware. The opt-out means everybody is considered to be organ donation till he or she said otherwise. And I think this is where we need to get into some sort of good conclusion. I know there's a lot of work being done by Minister of Health in Britain, and they're trying to get like multi-phase to be in a group and to find a way to encourage this. There's a plenty of issue anyway in different culture. Probably maybe nothing to do with the religion itself. It's a cultural issue, I'm afraid. And this is really affecting what's labeled as religion or as a cultural issue. Again, I think in the Muslim community, normally it's done by institution rather than just by individual scholars, because you need you need a group, committee, majma' fiqhi to have to be supported by the medical side as well as the people who knows the rulings to make.
So with this opt-out option in organ donation, you are a donor unless you specifically sign the form saying, no, my organs are not for donation. This is already being practiced in Singapore. Now, I think this goes bang against the first concept of bioethics, i.e. autonomy. Yeah? I.e. the right of the person to determine what happens to his or her kidneys or heart. Yeah? So, at the end of the day, we also need to consider another principle whereby you need to consider the good of the maximum benefit for the society compared to the person. This is a concept of utilitarianism. So you have to balance that. But and that is something that the nation has to discuss within the context of the different cultures that you have. Wallahu a'lam.
Friends and colleagues, we're right out of time. Thank you very much, and thank you again to our speakers.
Thank you very much. We've got no problem because we are charitable. Yeah, we are licensed in Louisiana as a charitable organization.